Hello guys, welcome back to Pathology by Ranjit YouTube channel once again. So here we are going to discuss about a very normal simple lymph node and also its variations non-neoplastic like a reactive lymphadenopathy, right? You must have had a tiny sore throat and a tiny lymph node here or lots of dandruffs and tiny enlarged lymph node here, right? So what are the findings seen in a reactive lymphadenopathy, the patterns and also normal lymph node architecture. If you're ready for the game as usual, put on a big smile and let's start and learn pathology and medicine more beautifully, fine? So first, a simple structure of a lymph node, right? A normal lymph node has a capsule, it has a cortex, the outer one is the cortex, the inner one is medulla. Anywhere, any organ, medulla will be more having the vascularity and little bit of connective tissue. Cortex is where the primary lymphoid structures will be, right? In the cortex, I have an area called as follicles. I'm sure you must have seen this in a normal lymph node, even in histology, right? And also the paracortical area, right? The follicles are primarily made of B cells or B lymphocytes, right? And the paracortical and parafollicular area is primarily made of T cells, right? T lymphocytes. That's a location in a normal lymph node. And we have something called a sinus. So what does exactly a sinus mean is, let's say I'm having a lymph node capsule here. So every antigen is going to come via the capsule. So the capsule kind of goes inside and it forms a very tiny area called as a sinus. Every reticuloendothelial system will have the sinus. So the cell kind of goes here, enters the sinus and then enters into the lymph node where I have the follicle and the paracortical area, right? So this is the point of entry, kind of a point of entry. We call it a sinus, right? So these are the three important areas you have to understand for us to know the reactive lymphadenopathies. Because I have something called follicular hyperplasia, I have something called paracortical hyperplasia, and then I have something called sinus histiocytosis. Let's go to Robbins. We all say that Robbins is very difficult to read, right? It's not difficult at all. If you know normal, Robbins is a piece of cake. Let's understand. Fine. Let me zoom this a little bit for you so it's much more easily visible. I hope it is visible now. Okay. So this is from the reactive lymphadenopathy, chronic non-specific lymphadenitis from Robbins, right? So follicular hyperplasia. Follicles had B cells. So if follicles is going to undergo hyperplasia, there's going to be more B cells. B cells produce plasma cells and antibodies. So in other words, any disease where I have a humoral immunity, right? Any disease where I have a humoral immune response, obviously you'll have more amount of B cell hyperplasia, more amount of follicular hyperplasia. One, very simple to understand, that's all. You'll have lymphadenopathy, which will be bigger and clinically, and where all I will have this follicular hyperplasia, fine. The causes. These non-specific things, we'll definitely learn them in the detailed classes whenever we go through, but just now to overview all the important information, that's all. So cause of follicular hyperplasia is going to be very, very simple. It's going to be causes which will have more amount of B cell hyperplasia. Every autoimmune disorder, whatever may be the autoimmune disorder, here we have named as rheumatoid arthritis, that's all. Any autoimmune disorder will have more B cells, more antibodies, follicular hyperplasia. Bacterial infection will have acute follicular hyperplasia, might not be chronic, fine. That's why it's not written here. Toxoplasmosis, again, lots of antibody production. Early HIV infection, not the late. Late will have depletion and everything. Early HIV infection will have antibody production against the HIV virus. That's what we use in ELISA to discover, right? Early HIV infection will have this. These are the conditions will have a chronic follicular hyperplasia in a case of a chronic non-specific lymphadenitis. Let's go to the second one. Second one was the paracortical, where we had T lymphocytes, that's all. Second is paracortical hyperplasia caused by stimulus triggered by T cell mediated immune response. Simple, virus. T cell means it's going to be a virus. Classically, it's infectious mononucleosis, right? You have in this region a structure called as an immunoblast. This might come in an exam, fine. Immunoblast is a kind of a bigger immature cell, which will be predominantly seen more in this patient with a very prominent nucleoli, fine. That's very simple. A prominent nucleoli, okay, and moderate amount of pericytoplasm will be there in case of lymphoblast. So anything which is viral related, if you feel it's not going to produce lots of antibodies, like in early HIV virus, where there are lots of antibodies, you'll have follicular, not much of an antibody like an infectious mononucleosis, Epstein-Barr virus, you'll have paracortical regions only initially, fine. Okay, the third is very interesting and is important for us to understand as well, fine. Let's pull this guy here, called as sinus histiocytosis, or the older name is reticular hyperplasia, right? I would say the newer name is more important for us, the sinus histiocytosis, that's how we report, or reticular hyperplasia is the older name for it, right? It's simple. Let's go back to what was sinus. Sinus was the point of entry of any cell into the lymph node, right? Okay, and there'll be exit via the medulla, okay? Now, it enters here, it exits here. Let's assume I close the exit. Everything will enter. What will happen to the sinus? Bigger. That's all. Very, very simple, right? So sinus histiocytosis, you'll have an increase in number and size of the endothelial cell because sinus is nothing but space lined by endothelial cell, right? And also you'll have increased number of intrasinusoidal macrophages. Every sinus will have macrophage. liver, Kupffer cell, spleen, littoral cell. Here, just histiocytes, that's all, fine. And which distorts and expands the sinusoid, which means the primary problem is something in the outflow is getting obstructed, so this balloons up, that's all. So what will obstruct it? The classical places here. Prominent lymph nodes, draining cancers with carcinoma of breast, right? I'll explain this to you. It's a very beautiful concept. You have to understand. Once you understand, you'll never ever forget it. It's not only here, you can extrapolate to multiple things, right? Let's assume I'm having a breast cancer here. And this breast cancer is drained by lymphatics here, okay? Which goes to a lymph node here, fine? Can I say breast cancer will have lots of fibrosis? It might, right? So this might get blocked. So because of the intense fibroblastic response, there's a possibility that this sinuses might dilate. This sinus might dilate slowly, right? So if you have a radiation, there'll be fibrosis. Lymphatics are destroyed. Lymph node becomes big. So anything which is causing an intense fibroblastic response or a radiation-induced fibrosis or a cancer-induced fibrosis, the draining lymph nodes will have sinus histiocytosis or radicular hyperplasia. Very, very simple. It's pretty common in case of breast cancer because serous carcinoma of breast, extremely hard, and that fibrosis causes all this dilatation. That's all. There are three simple things. Let's deep dive once more and look at the images, right? You were worried about image-based diagnosis, right? Nothing. Follicles are more? Yes. Obviously, what is this? You will definitely say it's in case of follicular hyperplasia. Very simple. What you see is what you read. What your brain knows, your eyes will definitely see, right? Follicles are here, but what's more big here is the cortical area. Look at this area. Especially this area, you're not having much of follicles. It's more of the paracortical, right? This is your paracortical hyperplasia. Maybe in a maybe in case of an infectious mononuclear EB virus infection, right? Here, this is my follicle here. So what's becoming big here is the sinuses. Right? There's a sinus which is becoming big here. That's my sinus histiocytosis, right? This is from ASH, American Society of Hematology, right? This is a classical case of a sinus histiocytosis, right? Perfect. So we learned three important chronic non-specific lymphadenitis, and also we know the microscopy of it. Put in the comment section, what is the next thing you want to learn? Let's learn pathology and medicine the most best way possible. If you're not subscribed yet, click on the subscribe button. See you soon. Till then, bye-bye.